Hello, everyone. It's 1 o'clock, so I'm going to go ahead and get us started. Welcome. My name is Tyler Harvey, and I'm a second year in the MD PhD program here at the Yale School of Medicine. Together with my co-moderator, Dr. Lisa Puglisi, and on behalf of the Sage Center for Health and Justice here at Yale, we're excited to welcome you all to this webinar entitled Caring for Criminalized Patients, Learner-Led Initiatives for Medical Education. We would like to begin by thanking our co-sponsor for this event, the Health Equity Thread at the Yale School of Medicine. So to begin, I'm going to go over some housekeeping guidelines for our time together today, and then we're going to give a little bit of framing before we turn it over to our panelists. First, this webinar will be recorded and will be sent out to everyone who registered before the event today, as well as posted on our YouTube and on the Sage Center website. Next, we'll have a dedicated time for questions from the audience during the last part of the webinar today. Please place your questions in the Q&A box throughout the webinar, and we will try our best to get to all we can by the end of our hour and a half. So before turning it into our speakers, Dr. Puglisi and I wanted to frame why we are all here today and set the stage for our panelists. I'll start by going back in history some. Over 50 years ago today, the US set out to implement a socio-political experiment that consisted of laws and policies, including those that are part of the war on drugs, that led to what is now known as mass incarceration. Since then, millions of individuals, disproportionately racialized, minoritized, and poor ones, have been impacted by the criminal legal system, with many, many more families and communities experiencing the indirect effect of this system. As a result of this, today, patients within our healthcare system who have been touched by the criminal legal system have unique health and social needs, partly due to the exposure of the system alone, but also partly due to the social positions prior to and following this contact. This explosion in the number of people being impacted by incarceration and its health harm is part one of the backstory today. The second part of that backstory is that the health system and those within it have played active roles in assisting the criminal legal system in enacting those harms. It has done so through numerous ways. The first I want to highlight is that the health system's inadequacy and unpreparedness to meet the unique needs of patients with criminal legal system exposure has translated to this group of patients receiving no care or substandard care, experiencing stigma and discrimination within healthcare settings, and ultimately leading to worse health outcomes among this group. On the flip side, this has also included the failure of medical education and health systems to adequately equip health providers and health trainees with the knowledge and skills to care for this group of patients. Next, the health system has played an active role in implementing health-harming practices behind bars, included but not limited to health providers participating in the execution of death penalties and forced sterilizations. More, the health system has also embraced and validated practices of the criminal legal system within community healthcare settings for patients, such as the shackling of patients, which we will hear more about today. So part of the work we're hoping to collectively do today is think about the ways to undo the harms enacted by this legacy and its afterlife within the health system through medical education, which I'll now turn it over to Dr. Puglisi to contextualize this for us more.
Good afternoon or good morning, depending on where you're joining from. Thank you so much for being here with us today. This is an absolute joy to be hosting this along with Tyler and to have our panel here today. I'm Lisa Puglisi. I'm an internist who cares for people leaving incarceration here in New Haven, Connecticut. And I also oversee the education component at the SAISH Center for Health and Justice at Yale School of Medicine. First, I will say that this webinar today grows out of a long history and tradition from faculty, students, and trainees working to improve the health of patients impacted by incarceration. I acknowledge the work of those who I know who have come before me and before us, the Academic Consortium on Criminal Justice Health, and its members at UMass, GW, UCSF, UMDNJ, and others across the country, were places where faculty for years have been leading initiatives to advance health profession education in this arena. There are many initiatives which I haven't mentioned, but suffice it to say they are broad and it happening in schools across the country. I also acknowledge Jason Glenn and colleagues at Kansas University School of Medicine working to build a curriculum repository for educational tools to teach on the intersection of mass incarceration and health. Stay tuned. And colleagues I have worked with here at Yale, such as Carmen Black, Kathleen Atkin, and Sharon Osborne, who have been doing work locally and nationally to teach health profession students and practitioners. And this should all be just the start. So the goal is that this work creates a groundswell of other initiatives across the country. Second, this webinar is squarely focused on learner-led initiatives within medical education for criminalized patients, which I believe is so important because it highlights the necessity of prioritizing and empowering those within medical education systems to lead these changes. In my mind, this means both that faculty can learn from students on what they need to appropriately learn on how to care for this population, but also that students should feel empowered to go to faculty and bring about changes within their own institutions. I note with a caveat that this should not have to be student-led. There should be a remarkable amount of collaboration, but there's a grand role for students bringing forth their needs and ideas. Before we start, I want to remind everyone about the aims of this webinar, which are: one, to showcase learner-led initiatives to develop curriculum and advance policy for the care of criminalized patients in health profession schools and other training programs like residency programs, et cetera. And two, to discuss facilitators and barriers to employing strategies to improve learners' education and skills surrounding care provision for criminalized populations. Last, I hope that this webinar today can spark new ideas and initiatives, new collaborations and conversations on how we can all work together to improve medical education surrounding patients impacted by mass incarceration. I encourage you to share the work you are doing here in the chat so we can learn more about you and your work. So share your identities, your projects in the chat, and your questions in the Q&A box, please. I'm going to turn it back over to you, Tyler.
Thank you, Dr. Puglisi. I'm excited to introduce our first pair of speakerless and panelists from the Johns Hopkins School of Medicine, Karen Chi and Victoria Collins. Karen is a third-year medical student at Hopkins, planning to pursue a career in psychiatry. She took the elective healthcare in the age of mass incarceration as a first year in the program and has since volunteered to organize the class in following years. She introduced a new session with clinical case discussions facilitated by physicians who work with patients inside the Baltimore City Correctional Center. Outside of the course, Karen is also interested in health policy and the history of psychiatry, and her other projects include research on the deinstitutionalization in Baltimore and political advocacy through her state and city medical societies. She will be joined by Victoria Collins, who is a second year at Johns Hopkins. Her interests are in carceral health, informed by her own experiences working with children in the Juvenile Detention Center, and her background in medical anthropology. Her research focuses on stigma as a barrier to health, and she is passionate about using advocacy and medical education to improve the care of criminalized patients. Karen, Victoria, thank you for joining us.
Thanks so much for having us. I'll just get started by talking a little bit about the history of the course and then why I became interested in organizing the course again, and I'll pass it over to Tori. But pretty much this course actually started as a student group on our campus in 2017, and it was led by M1s, first year med students. And it was also organized by students from the School of Public Health and School of Nursing, so it was a very collaborative effort. And what they did at first was organize panels of formerly incarcerated persons, and then they volunteered with people who were formerly incarcerated in the community, and they organized speaker events as well. And from there, they actually had the opportunity to organize a three-part elective on this topic. And it's really nice that our institution allows med students that opportunity. So I know of other student groups like a refugee health clinic, and then also like a planetary health student group that have done something similar. And so I think finding that opportunity to talk about what they have done and get more students interested is something that they really took advantage of. And so from there, the course has grown, like involving faculty advisors. We have Dr. Sufrin, who has worked on, she herself has done work on reproductive health justice. And Dr. Andres, who is another faculty advisor, he himself has experience being incarcerated. And after his release, he pursued an undergraduate degree and then a PhD, and then he created a nonprofit foundation to mentor formerly incarcerated individuals. And so we've had a lot of support from faculty, and that's enabled this course to grow further. And our eventually our several students published the curriculum on MedEd portal, and that's another opportunity that they were able to find. And so for me, why I decided to try to organize the course again is that I partly, like for selfish reasons, just wanted to hear the speakers again and wanted to see if there was anything that I missed the first time around, or see if there was anything new with the work that they were doing that I was excited to hear about again. And then as mentioned in the beginning, it relates to my academic interests as well. I'm interested in psychiatry, and I think that overlaps a lot with like the social determinants of health, substance use treatment, and then overlapping ethical issues like people being present in a system that has a degree of involuntariness, and that can vary in these systems. But I also felt like, based on my interest, I wanted to build a little bit more on the existing curriculum. So adding sessions that were more interactive and discussion based, and focused on clinical scenarios we could potentially encounter was something that I wanted to contribute. And that's pretty much how I got involved. And then the next year I passed it on to Tori. So I'm gonna pass it on to her now.
Yeah, thanks, Karen. So yeah, my interest in the course stemmed from kind of a broader interest in caring for patients who either have diagnoses that are stigmatized or hold other kind of stigmatized identities. And then also my experience as an undergraduate in St. Louis, having an opportunity to spend time in a juvenile detention center. So I spent one night a week there, and was just really struck by the fact that there were children, you know, as young as 11 or 12 being incarcerated, and even sometimes being tried as adults, and also by the really glaring racial disparities that I witnessed there as well. And so that kind of sparked my interest in this topic. And then when I got to medical school and saw that this course existed, I was really excited to enroll in it and then to get to work with Karen during my second year to run it. And so we just finished up this year's course last month. It is kind of under the umbrella of a Foundations of Public Health and Ethics course. And as part of that, first year medical students are able to choose one of around 8 selective courses. So it's 3 one-hour sessions over 3 weeks. And so prior to the course, we ask students to watch Ava DuVernay's movie 13th to give them kind of a history of mass incarceration. And then our first session kind of reiterates that history, and it's done by an OBGYN and faculty member who has experience providing reproductive care in San Francisco jail. And is also a medical anthropologist and kind of brings that view. And so she talks to students about, what it's like to provide care in a carceral setting, and then also a lot of the kind of ethical issues surrounding reproductive justice in carceral settings. And then the second session that we have, as Karen mentioned, is with a fantastic faculty member who does endocrinology research and is on faculty at the Howard University School of Medicine. And he spent 10 years in prison as a young adult. And so he shares that experience with students and talks about some of the challenges that he faced both while incarcerated and afterwards. And then also offers some advocacy opportunities or opportunities for students to be involved with his organization and others in the Baltimore area that are supporting current and formerly incarcerated individuals. And then in our third session, which is the one that Karen introduced last year and has been a huge success, we bring in 4 physicians who work in the Baltimore City jails. And so they're able to speak to the experience of caring for patients. They work at the location where anyone who's arrested within Baltimore City is brought there initially. And so they talk about some of the challenges of caring for patients who are constantly being moved from place to place or who may not know, when they're going to trial or when a release date is. And so they spoke specifically about substance use disorders, and the high prevalence of those among patients who are incarcerated. And then they also brought cases that are real cases that are de-identified of patients that they care for, and that speak to some of the most common issues that they face around infectious diseases in really high density settings like jails and prisons, as well as chronic illnesses, substance use disorder, and the ways that they try and advocate for their patients to have access to medication assisted treatment or other necessary medical therapies. And then the course concludes with an action-based writing assignment. So students submit a 1-page write-up of what they learned in the course and how they hope to apply that either in the care of their future patients or in other advocacy endeavors. And so as we kind of look to the future, we got fantastic feedback from students about ways that we can continue to expand the course. So they're interested in learning more about ways that they can better support patients who are returning from incarceration, since many of them may not work in carceral settings, but especially in Baltimore, are really likely to work with patients who have been impacted by incarceration. And so we're planning to do that. And then also a couple of this year's students approached me at the end of the course, interested in starting a student organization. So we're really excited to be able to kind of go beyond education and start to expand our efforts into community-focused advocacy alongside incarcerated people.
Thank you, Victoria and Karen, for that. One quick question before we move on. Just because I know we have a broad audience here today, could you all explain what a selective is, just so we're all on the same page?
Yes, absolutely. So this is within the structure of this public health course. There are 8 selectives in this kind of batch that range from like the ethics of death and dying and palliative care to sexual medicine. And so students submit like a ranked preference list saying which topics they're interested in. And so this has been, among the most popular of the selectives that were offered in this session.
Okay, great. Thank you for clarifying that. And I'm sure we'll have more questions for the Q&A for you all. I'm gonna move us along to our next panelist, who is Dr. Michelle Suh from the University of Chicago. Dr. Suh is an emergency medicine physician researcher. She completed her medical education and residency training at the Baylor College of Medicine, and she is currently a medical education fellow at the University of Chicago. Her expertise is in the care of vulnerable patients and medical education, and she is particularly focused on the hidden curriculum surrounding patients with criminal legal system involvement and also potential interventions that can ensure equitable, high-quality care for this population. She has lectured nationally and served on numerous professional committees and has also published in academic journals such as Academic Medicine and the Journal of Graduate Education. I'm going to turn it over to you now, Dr. Suh.
Great. Hi, like Tyler generously introduced me, I'm Michelle Suh, pronouns are she, hers. I just want to say thank you again for the invitation. And it's actually really almost surreal being on the panel because all of these speakers and our hosts, like I've cited and referenced your work numerous times. So very grateful to be a part of this conversation. We can just go to the next slide. Working in the ER, it had been a typical Saturday night when we got kind of a routine trauma call from EMS about a patient with a stab wound to the chest. And, it sounded like a pneumothorax. It looked like a pneumothorax. We were getting ready to set up for intubation. And then we realized that the patient was actually handcuffed and the police officer was back at the scene. And, in that moment, it became very apparent, right? We can know all the medical things, the oral board question answers, but unless we actually know how to address like the lived experiences of our patients, we oftentimes fall too short. So next slide. I've helped kind of, put on undergraduate medical education electives or residency didactics, but my goal here today is actually to talk more about kind of a framework or even mindset for how we can approach this work, especially in medical education. So I would argue actually that our standard of care for incarcerated patients oftentimes falls short and does not meet any standard of care. And at a time when we're trying to address more of the social determinants of health and the structural vulnerabilities of our patients, that too often we leave out our patients who are incarcerated or have criminal legal system involvement. So today I want to talk really about 3 things. First is, what is the hidden curriculum that we actually receive surrounding incarcerated patients? And second, how can we incorporate ethics, especially the idea of dual loyalties? And then third, what are things that we can begin to do to try and address it? So next slide. I think we're all aware with this graphic where the United States represents 5% of the world's population, yet we represent 25% of the world's prisoners. That's over 2 million people in our prisons and in our jails. And for context, that's actually double the amount of people with PEs and DVTs. Yet when I think about how many lectures, especially being EM, that I received about PEs and DVTs, we definitely don't receive the proportionate amount for incarceration. In fact, one of my first forays into PubMed about incarceration, I got so many results about incarcerated hernias more than incarcerated patients, right? So next slide. So that actually makes me think about this quote by abolitionist and scholar Ruth Wilson Gilmore. She writes, "Prisons are designed to absorb people, those people who have been abandoned by the state." And I would actually argue that they've not just been abandoned by the state, but by medicine as a whole as well. Next slide. And so that brings me to the hidden curriculum. And so this is kind of a crash course in med ed, but we have our explicit curriculum, right? So this is the thing that's listed on your syllabus, your course objectives on your lecture slides. Then we have this idea of an informal curriculum, right? What are the epic smart phrases you use? Like when you're walking in between patient rooms on rounds and you're getting a crash course on like the asthma guidelines and things. And then we have this idea of a hidden curriculum. And that's kind of the socio-cultural values, expectations, even ideologies. Sometimes it's things where it's like, be really nice to your charge nurse, or things like the Patagonia is the new white coat. But when it comes to our incarcerated patients, that hidden curriculum actually becomes much more problematic, right? And it's really marked by, I would argue, three major ideas. The first idea is this idea of diagnostic skepticism or bias towards our incarcerated patients. I hope you have not had the experience of hearing the term incarceritis, but something I heard thrown around quite frequently, right? The idea that, oh, these are violent, malingering patients who only started having that chest pain once the handcuffs came off, right? And that diagnostic skepticism is dangerous because we know that patients who are incarcerated are actually much more vulnerable, even from a medical standpoint. The second aspect is the idea that it's okay to infringe on prisoners' rights because they're incarcerated, right? So we sacrifice bedside privacy when we're taking interviews with our patients. We don't ask the officers to step aside. Whereas if you're interviewing a patient who's not incarcerated, any kind of strangers, right, you're going to say, oh, sorry, can you give me a second with the patient? We also sacrifice the idea of like equal care for our patients, especially with our learners. There's a good qualitative study earlier about medical students describing like greater autonomy, right? But at the risk of the incarcerated patients' health. And then the third idea for the next slide is this idea of like being overly deferential to third parties. So dual loyalties is really about this idea. We ideally have one relationship, one loyalty, which is to the patient. Sometimes it's the case manager asking you to discharge the patient early, right? But in cases with incarcerated patients, it can often be a police officer, the correctional facility, right? And that third party oftentimes carries a lot of gravitas or sometimes even legal authority. So for the pneumothorax patient, right, it's easy to override the officer's desire to keep the patient shackled. But what about when your patient's in the fast track area in the ED and administration wants you to just give them the quick medical clearance and discharge them? What about when it's, discharging your patient who's in psychiatric crisis because the jail has mental health services, but we know that those are substandard or understaffed? And so it's really difficult, I think, with incarcerated patients trying to navigate that. And so next slide. I think there's a few things that I would argue for. One, I think there actually needs to be a paradigm shift in terms of viewing patients as vulnerable, not violent offenders. And I think going along with that is understanding, second, that there is a hidden curriculum and that in the absence of explicit curriculum, just exposure to these patients is not enough. And oftentimes we're actually teaching medical learners to perpetuate the same behaviors and attitudes that led to these disparities in the first place. I think third, built into that is also understanding when those situations of dual loyalties arise. And then fourth, in addition to your explicit curriculum, really having explicit policies, right? What are my shackling procedures? How do I escalate to get these removed? What is our policy regarding officer presence? How close they have to be, whether we can take private histories, and also trying to work with facilities about our transitions of care. How can we actually ensure follow-up, adherence to the discharge plan? And then little arrow. The last thing is this idea of, well, it's supposed to be a cute little animation that's going upstream, because I really want us to think about the upstream factors, right? Addressing the root causes of mass incarceration so that we actually don't have to deal with correctional facilities in the first place. So next slide, I'll leave you with the quote by Derica Purnell. She writes, abolition, I learned, was a bigger idea than firing cops and closing prisons. It included eliminating the reasons people think they need cops and prisons in the first place. And so I'm really excited to be part of this conversation. If you have any questions or want to reach out, next slide, that's my email. Thank you.
Dr. Saw, thank you so much for walking us through that. I love how you started with a clinical scenario and really kind of framed us and ground us in the care of patients, which is why we're all here. And definitely have lots of questions for you in the Q&A, and I hope others do as well. Just as a reminder, feel free to put your questions in the Q&A box, and we will get to those. I am now going to turn it over to our last panelist, which talking about those explicit policies that Dr. Saab mentioned. We'll hear some about that. So I'm excited to introduce Neil Singh Bedi, who is an MPH student and research scientist in Boston. His research and advocacy endeavors lie at the intersection of public health and clinical care, with a vision to make health systems more sustainable, effective, and equitable, like the other panelists we have heard from so far. Neil Singh is a rising fourth-year medical student at the Boston University School of Medicine and currently a Zuckerman Fellow at the Harvard Chan School of Public Health and the Harvard Kennedy School Center for Public Leadership. He is founder and co-director of Stop Shackling Patients, a student-led movement aimed at bringing an end to the universal shackling practices in hospitals across this country. Neil Singh, we're excited to learn from you today.
Tyler, thank you so much for that introduction. And thank you again to the team at Yale for creating the space for everyone to have this conversation today, and to my co-panelists who've done a phenomenal job explaining all the amazing work that they're up to as well. I just want to start today. So for those of you that know me, you know that brevity has never been my strong suit, but hopefully today we'll keep my thoughts succinct. But I want to start just by sharing the story of where our project Stop Shackling Patients came from. It actually came from one of my first experiences as a medical student taking care of patients in the hospital. For those that aren't familiar, the first thing that med students learn when we're starting to engage with patients is how to do a patient history. And there are patients who will often offer the opportunity to interact with them like real patients instead of a standardized patient or an actor. And so we actually go to the wards with a fourth-year preceptor. And, the fourth-year preceptor will ask a patient, hey, I have some first-year med students. Can they practice with you? And so my first year, I had a preceptor, his name was DJ, and he asked a patient who was incarcerated, I have a first year med student with me. I was the first year med student. Can they come interview you? And so we go into this patient room, and I'll never forget meeting this patient. She was incarcerated. Her leg was shackled to the bed, and she was, barely over 100 pounds. She had a terminal diagnosis and was here for quite a while at the hospital. And I just remember every time you would have a conversation with her, every time you asked her a question, she'd try to slide up in her bed. And then the weight of the shackle was so heavy and she was so small, it would just drag her right down the bed. You can hear the shackle clanging against the plastic of her hospital bed louder than you can even hear her voice. And just around the same time I had that experience, I had taken a class with one of my closest mentors, Dr. Sandra Crosby, who eventually helped us lead this movement. And she's an internal medicine physician, but also a professor of human rights at the B School of Public Health. And one of her mentees, Tyler Liskier, wrote an op-ed in the Washington Post about a patient of his who was shackled to their hospital bed as well, and actually was undergoing cardiac arrest and died in shackles. And as tragic as this sounds and as tragic as this is actually common practice in hospitals across America when patients are brought from corrections facilities to inpatient healthcare facilities. They're kept shackled regardless of their clinical circumstance. And until recently, patients were actually even kept shackled while giving birth, as traumatic as that is. And so the question that I asked DJ, my fourth-year preceptor, when I walked out of that room was, we still do this. I was in shock the first time I heard it. And that sort of brought the team together. So myself and two of my colleagues, Nisha Mathur and Judy Wong, also med students at the time, first year med students, we figured, this is something we could do something about. And so Dr. Puglisi, next slide, if you will, please. The first thing that we were trying to figure out was, do we want to advocate for a change to occur, or was there a way we could actually create a change within the system we were operating in? And these are two slightly different things, but the distinction here is important because advocating for change is something that we're talking about more in medical education, right? How do you bring awareness to issues that are, Dr. So said so eloquently, perpetuating behaviors and attitudes in medicine is something we're very good at, right? Because we don't like to shake the system and we feel like well, this is how it's always been done, and therefore this is how it should continue. But if you want to actually bring a change to the system, it requires a little bit more effort and a little more strategy, I suppose. And that's what we really want to focus on. And next slide. For our journey for stop shackling patients, the first and most important thing was finding good mentorship. And so we had a lot of amazing people sort of in our corner as we try to figure out how can we get a policy enacted at Boston Medical Center where patients could actually have an expedited process of individualized assessment so that they could have stronger advocacy behind them to have their shackles removed while they were receiving care in our hospital. And over the course of many months, we actually wrote a petition to Boston Medical Center and said, "Hey, this is something we want to draw, attention to, and something we feel like we could do better about." And we went on to advocate at the state level and at the national level through the Massachusetts Medical Society and the American Public Health Association, and actually engaged in dialogue with hundreds of people over the course of months, trying to figure out, what were the specific ways that a policy could be designed, and then what would it look like if it was implemented. And then we eventually published our generalizable model in the Journal of General Internal Medicine. And about a year after we started all of this, Boston Medical Center became the first institution that we knew of at the time that actually adopted a policy to perform an individualized assessment on patients so that their care team could actually advocate for shackle removal, not because it was medically necessary, which is something that was possible before this, but simply because it was the right thing to do, because there was an ethics and moral reason that a patient should not be shackled to their hospital bed. And so the key point that I just want to make here was a lot of times the different levers that you will pull within your healthcare system, especially as a trainee, are going to vary depending on what you're trying to change, right? What's the specific goal that you have in mind and your team has in mind? Who you need to convince, because oftentimes it's not you making the decision, as Dr. So alluded to, it's not even the care team making the decision about removing a shackle from a patient. It's often multiple different systems intersecting at the bedside. And so how do you actually convince the right people that this is the right thing to do? And the last thing is figuring out how you can leverage your voice the most. And I wanted to make this note, especially for us as trainees. A lot of times, medicine is very hierarchical, and we're very good at sort of treating students as the bottom of the totem pole because you're just a medical student. And I'm a firm belief otherwise. I think as a medical student, you actually have a lot of power because you are the one who is going to inherit this healthcare system. And so you should have more responsibility than anyone else to say, I'm inheriting the system and I'm proud to operate within it. And next slide, please, Dr. Polisi. And as you're sort of going through your medical education, you'll realize that as you go on to enact change, change itself is something that requires a lot of work to sustain. And so, next slide. As we're sort of going through our medical education, people are going to tell you, that you should stay in your silo or stay in your lane or stay in your box. And medical education has a very clear set of guidelines and rules about how institutions approach medical education. But in reality, there's so many different systems, so many different boxes, if you will, that intersect. And at the center of all of this, and this is my last slide, are our patients. And I think more than anything, as we're sort of trying to figure out what we want our patient care to look like, we have to be willing and we have to be ready to sort of step outside of the boxes that we're in and say, can I go out and understand the way the justice system works and how that's impacting my patients? Can I go outside and meet some professionals in the field of public health and ask their expertise, or other clinicians? I mean, throughout our journey at BMC, the most valuable people we were hearing stories from were patients, and also from the nursing team at the bedside who said, yeah, I've seen this 1,000 times before. I've always wanted to do something about it, but I didn't know what I could do. And I really believe that at the place where all of this happens is when we're willing to step outside of the box and actually create change that way. And I'm happy to answer any questions about our work, and also hope to see that others here on this call and elsewhere continue doing this kind of work as well.
Thank you so much for sharing that work, Neil Singh. And something I really appreciated about your efforts is that it's so concrete, the goal that you all were setting out to achieve, and so feasible that it it was really just inspiring. A lot of times when we think about all the changes that need to happen, it can become overwhelming, or at least to me personally. But that was such a concrete goal that you all worked towards. We have a question in the Q&A that I want to pose to you, Neil Singh, because I think you may be positioned to answer it based off of what you presented to us. So an individual, I won't share the name, is sharing about their experience as a surgeon providing surgical care to incarcerated people, and writes, I think that forward progress on this issue will require not just educating people, but engaging hospital administrators whose primary concern is often simply security. I'm wondering if you could talk about how in your work you all engaged with hospital leaderships around this issue of security and safety.
Yeah, absolutely. A great question. And to answer this, I think at the beginning, so we started by writing a petition, which you can imagine if you're a student at an academic institution and you're basically telling your hospital system very publicly, hey, what you're doing is wrong and we think you should do something different, that sort of inherently creates a little bit of a confrontational start to the dialogue. Having said that, BMC, and especially I got to give credit to Dr. Nancy Gaden, she's our chief nursing officer and eventually co-authored the paper with us where we talked about the policy that we implemented, was actually our strongest ally in the healthcare administration. And more than even just thinking about like hospital administration's concerns around security, it's also the people at the bedside. And so having buy-in from our MICU nursing director, a lot of the patients that we were taking care of specific with this policy were patients in the ICU who were sedated, intubated, but still kept shackled. We actually made sure we involved all of those people in the dialogue, and all of those people actually became advocates themselves to hospital administration saying, hey, we're the ones taking care of these patients and spend the most time with them. And we feel like we could do something better. And for that reason, we think you should make this change. And so I think engaging hospital administration by engaging all of the other people who are going to be taking care of those patients sort of builds that momentum that's necessary to convince hospital administration that this is what they should do.
Great. Thank you. Thank you for following up and answering that. We now have some pointed questions from Dr. Puglisi and myself for about the next 20 minutes, and then we'll open it up for Q&A from the audience. So to begin, I have a question for Victoria and Karen. So it seems like the selective has taken many forms over the years. So Karen, you were speaking to how you incorporated those clinical cases during 1 year of the selective. I wanted to ask you both, and then of course, Dr. Neil Singh, feel free to chime in your respective work as well. How do you know this is initiatives, these new modifications are accomplishing their intended goal in these efforts?
Thank you for the question. That's a really important question because it's necessary to make sure that we're not just like putting this information out there and then just letting it be, and actually building these relationships and like motivating people to advocate and take action. And I think that for us, like our goal was to introduce people to the topic, and sometimes it was people who had personal experience working in these settings, but also we wanted to have the classroom be open to people who had very little familiarity with this topic. And so I think for us, like reading about the student reflections and then looking at student interest in registering for the course the following year, or finding facilitators for the course, and then I think with what Tori mentioned, with students being interested in reforming the club, I think that we acknowledge that sometimes like student interest and time waxes and wanes, and their ability to dedicate effort to this effort is going to vary. But I think that for us, it's been really exciting to see that people are interested in continuing this. And I think we're going to keep looking for ways to um, advocate more for our hospital administration and for in the policy space. I think I really appreciated hearing from Dr. Suh and Dr. Betty or that Neil Singh as well. Yeah.
Victoria, anything you would like to add to that?
I think Karen covered most of the points that I would make. I think it's encouraging to see students, continue to sign up year after year, and to also have them be pushing us to say, can we translate, like, can we do more with this course? Can we translate it into advocacy? Could we expand it to be, a core part of the curriculum instead of an elective? So that's been exciting to see as well.
Yes, yeah, it's very exciting. And I think also part of this conversation is one around sustainability of all of these efforts. As Karen and Victoria were mentioning, we move on in our medical training, even though it may be a very long road, feels like a long road at times. Dr. Suh, I have a question for you as someone who is more advanced in their medical training. How does this work live on as you move through the medical training process?
Great question. So. I think one way that we've kind of tried to address it is getting your buy-in from program leadership. I think I've been lucky, all the institutions I've trained at, people are committed to, health equity and taking care of our patients. It's just that this had been a blind spot. I know I've worked with people at Cook County who they've actually incorporated into their intern orientation, like training boot camp, a simulation where, they are learning about posterior MIs, but one of the factors in there is that it's a patient from the county jail and that they have to navigate the whole shackling conversation with the correctional officer, right? And so what are things that we know are always going to happen, and how are ways that we can actually attach that into it? We also, like at Baylor, for example, had like a social EM lecture series. And so we were able to identify, and I think he might actually be attending, but like Dr. Mark Robinson is an internal medicine physician who also works at our local jail. And so, he's someone who, God willing, will stay at Baylor forever. And so he's someone who can come back, right, and give those talks. And so a lot of times also, right, there's community organizations. And so are there ways that you can kind of build and partner with those groups, and that way you can have someone who has a little bit more longevity than kind of our 4 years in, 4 years out model.
That's great insights.
Dr. Suh, I just wanted to give you an opportunity to, before we move on, I know that you helped start an initiative at Baylor as well. Can you just mention it briefly?
Yeah, so we had a UME elective, which honestly is so similar to the Johns Hopkins one, where, right, we're trying to kind of contextualize like, where does mass incarceration come from, and what are these populations kind of experiencing before the incarceration as well. And I think that's helpful because our medical students, right, can enter into their clinical clerkships kind of aware, right, like these patients still have rights. The diagnostic skepticism and something that's harmful, right? And so that they're able to kind of be equipped to be bystander interrupters, right? So that when those conversations happen on rounds, right, they can be like, oh, like, what is the shackling policy? Even if you know what the shackling policy is, right? It gives a moment for your attending or your resident to, to pause and take a step. And then, like I said, for the residency, we had like some case vignettes that had common problems. Like we had officers requesting blood alcohol levels or urine drug tests, right? That like you do need a warrant for it. And I think that kind of goes back to Tyler's first question of how do you know that impact is, right? And I think it's ultimately like clinician behavior and patient outcomes, right? And so after our didactic, right, our residents knew like, oh, like, can I see the warrant before that? I will also say, like, in retrospect, we learned you do need to also like kind of think through the next steps, because some of our residents got threatened with arrest for obstructing the investigation, which, like, right, I hadn't anticipated it could get escalated, but luckily, like, our administration in charge were able to de-escalate that situation. But those are some of my rambling thoughts.
No, that's really helpful. And actually, you bring us to something that's really important to underscore. To every good idea and good intervention, there are often unintended consequences. And I wonder specifically, so you brought up a really interesting one that I had not heard you talk about in the past, and that's a big deal. Like, learners or residents, like, then creating trouble for themselves creates another host of problems, right? Not unsurmountable, but to be acknowledged and then addressed in anticipation in future iterations of any intervention. Neil Singh, I wonder if there have been some unexpected consequences or unexpected results of your hospital policy that you've had to think through with a broader team.
Yeah, definitely multiple, and some positive, unexpected consequences, some things that required some more reworking. One of the things that we didn't do, and hindsight is always 2020, and if I were to do this again, I think there's so many things we would have done differently, but working more closely with the corrections facilities that our patients typically come from. Um, Again, very classic to have like a more confrontational relationship with the folks coming from those facilities, especially as some of us have much clearer understandings of mass incarceration to begin with. And there were often times when, BMC had this policy, someone from the care team would call corrections and say, hey, actually, this patient meets criteria for shackle removal, and the corrections facility says no. And that back and forth actually does happen and has happened for a very long time, but it became more and more common as this policy began to unfold. And so one of the things that we had to kind of figure out was actually how do we build a better working relationship with the corrections facility and who are the right people that we can connect with there. And so conversations happening in the last couple of months and in the next couple of months that Nisha, my colleague, is actually leading are with the superintendent of our House of Corrections across the street where most of our patients come from and figuring out how do we navigate this conversation better? Who are the right people to call when someone on the care team says, this patient's meeting criteria for shackle removal? And I think one of the other things was the challenge that we have with implementation of the policy, where, it's great that the policy has changed, but that's step one of 100. And how do you make sure all of the residents are aware, all of the nursing staff are aware? What's the best forum to disseminate that information? Does everyone get a mandatory training? Do you include it in like rounds, a couple of weeks? So figuring out all of these details is super important and something we didn't expect at the beginning, but are good things to keep working on. Yeah, I'll leave it there.
Great, that's really helpful. It also leads me to another question, which is I'm curious, and this can be for various people on the panel, but I'll start with you, Neil Singh, is so you did a policy intervention at the hospital level. Students seldomly know anything about what hospital policies are. Like, that's not their focus on learning. And so has that at all, or how does it trickle into the med school curriculum?
For the record, I also don't know a lot about policy and only know
Oh,
very little about the couple of policies we've worked on. I think very little overlap exists between understanding healthcare system policy and what is considered traditional medical education. And part of that is you can only fit so much about biochemistry and learning about what an EKG should look like and about health policy within 3 years of medical school or 4 years of medical school. I think a lot of the learning that we had to do around the healthcare system and like even what policies existed at BMC and at other institutions was done outside of our academic space. And I think BU specifically as a medical school does a really good job of incorporating a lot more of the public health-esque and systems-based thinking that is necessary for medical students to be aware of and clinicians to be aware of. But there still isn't a lot of overlap, and I think that's one of the areas where all of the work that everyone on this panel and a lot of the attendees are doing is figuring out how do we bring more of that conversation to the forefront for med students. But a lot of the learning was done on our own, and a lot of the learning came from people much smarter than us who were our mentors who said, this is the policy you need to change, this is how you're supposed to do it. So every time we didn't know the answer to something, which was often, we just asked someone else. And there were a lot of people willing to help us, which was a big part of the reason that anything happened.
Great, thank you. I wonder, kind of vice versa for the rest of the panelists, like, are there ways you've noted that a curricular intervention, so a didactic or a selective course, has at all translated into more policy stuff or broader med school or hospital changes? Like, is there any interplay there or none that you see?
I think it can be like a culture shift. I know that so we had done the medical school elective, and the teacher and I, Mark Robinson, and I had published a commentary. And then as those medical students were entering into their clinical clerkship space, bravo to them on their course evaluations. They were asked about, mistreatment, professionalism, and they started reporting, hey, we're hearing like a lot of really biased comments that are not appropriate. Like, we feel uncomfortable about how our patients are being discussed. And so it led to the clerkship directors, right, sending out emails to the faculty and just being like, let's actually take a moment and reflect or interrogate our own attitudes and be mindful about what kind of messages we're actually trying to teach our medical students. That's not like a policy per se, and I think we definitely need them, but I think policies oftentimes come out of like a need, and I think there needs to be some kind of tension that our current status quo is not meeting what we purport to believe or act.
But I'm hearing moves towards practice change, if not policy. Tori or Karen, anything you all want to add?
Yeah. I think, the question is definitely getting us thinking. I'm not sure that we have real instances to point to right now. We know that a lot of the students who have taken our course have gone on to work with the faculty who teach the course in research. And we also know that Johns Hopkins is right now in the process of creating or revising their policies around caring for patients who are incarcerated. Although I don't think that that's explicitly linked to the course, but I think it's definitely something we're thinking about, is how we can kind of tie those two pieces together, and also maybe how we can kind of get that information, because after students go out, we don't necessarily know what they do with the knowledge from this course.
I will say, when systems change, I'm not involved with this at all, but I know some hospital systems are actually starting to incorporate this idea of like an incarceration consult team in like the ED when situations arise, right? Oftentimes it's just like, well, what do we do? And it's like what we do, not what the official policy is. And so if you can have someone like our geriatric consult team or your addiction medicine team, right? And you have like an incarceration consult team who can advise you on like what actually should be done for the patient.
I think the last thing I'll add really briefly is that like I agree with Neil saying that working with people who are more knowledgeable than you can really like help you formulate what you want, like what your next steps are, and like who you can collaborate with. And one of the faculty we worked with, Dr. Suffren, she's like a really big advocate for reproductive health justice, and especially advocating against shackling of pregnant inmates. And so I believe that she has done like policy advocacy at the federal level. So this is not just about like hospital policy, and she's worked on addressing banning shackling pregnant inmates at federal prisons. So that's not necessarily going to address like every single carceral setting, but it's like a step in the right direction. And it's I think that really helped us think about like what exactly can we do, and what like how big our goals can be, and then also thinking like what can we do at a smaller level in terms of education as well.
Yeah, this is great. Thank you all. We're about to move to question and answer from the audience, but I have one last question for all of you, and try to take about like 30 seconds to a minute if you can. And the question is, What does a more ideal future medical education system look like for patients experiencing criminalization and also trainees learning to care for them? And Dr. Sa, I'll start with you if that's all right.
Well, thank you for that easy question. I mean, honestly, I think our like first goal has to be like no incarceration, right? Um, we know that we get way more bang out of our buck for preventative medicine, and I feel like the same can be said for our social problems, including incarceration. I think like also trying to be pragmatic, understanding the structural vulnerabilities, right? That incarceration is not like a moral failure a lot of times. And I think it really speaks to, we're really all in this together. If you're going to judge someone for being incarcerated, are you also judging someone for their body weight or for smoking and things like that? And I think really trying to do our best to provide care for everyone that like honors human dignity is important. I think that's a very lofty goal and not pragmatic. I think pragmatically, ACCJH is like an academic consortium. We're working on a set of like curriculum core competencies, which in medical education speak, right, is like the rubrics or the skills you should be able to do and know before you graduate. And I think trying to really like formalize that is like one of the steps we can work towards.
Great, thank you. Neil Singh, would you mind going next?
Um, a lot to cover in 30 seconds to 60 seconds, but I think two things. One is I hope a future looks more like a space where the correct voices are heard. I think everyone on the panel discussed this in the electives that they've worked on in the different forums they've created is listen to the voices of people who are formerly incarcerated is the most valuable learning tool when anyone wants to work in this space. And so I think that's the first and most important thing. And the second, I would argue, is medical education of the future and of today and the future should focus on giving trainees the space to create change that they want to see within their healthcare systems. And that should be the norm and not something that is a one-off from like a couple of students a year in healthcare institutions. And so I think those are the two things I would fight for.
Great. Karen, would you like to go next?
Sure. I think one thing I was thinking more on like a local or like smaller level, but I think trying to incorporate more stories from people who are currently incarcerated or formerly incarcerated. Like I know our school has this part of our core curriculum called clinical correlations, and this is basically where they invite patients to talk about their experience with living with an illness. It would be amazing if we could hear from this marginalized population directly, and I think that thinking more broadly, trying to find ways to make the carceral system more rehabilitative. And as physicians, we have this role in rehabilitating individuals and their physical health, but I think that we can also start to think about like how they can more effectively transition back into society and lead a healthy life. And then also have the setting itself be something that is not so punitive and not so abusive towards this marginalized population. So
Thank you. Thank you. Victoria, would you like to wrap us up on this question?
Sure. I think as Dr. Suh said, I think the most ideal and the goal that we'd like to work towards is not having these carceral settings exist and not having so many patients who are dealing with the fallout of this. But I think, short of that, as Karen said, incorporating more opportunities to hear directly from patients. I know in the courses that I've had so far, these clinical correlation talks where patients share their experiences with us have been by far the most impactful. And so I think incorporating that and potentially opportunities to do clinical rotations in carceral settings and to see some of these issues firsthand would make a really big difference. And then I think expanding this kind of education from being, an optional part of a curriculum that maybe a small percentage of students elects to learn about, but having it be a core part of the curriculum because it is something that no matter what field of medicine we go into, it's going to be affecting our patients. So learning kind of woven throughout our courses, how do you care for a patient with diabetes when they're in a setting like this, I think would be good places to start at least.
Great, thank you all. I'll start with questions from the audience now. So just as a reminder, feel free to put audience members, feel free to put your questions in the Q&A and we'll try to get to as many as we can. One of the first ones we had is coming from a first-year public health student here at Yale. And they're curious to hear all of your thoughts about how medicine and public health can work together, and particularly how can public health students and professionals contribute to this work of caring for criminalized patients. I'm wondering if someone would like to contribute thoughts to this question to begin.
I can start only because I'm getting my MPH this year as well and not doing anything in clinical practice. And so I think I can see both worlds a little bit better. There's so much I feel like, and even from like during the SSP campaign, a lot of us and from the medical school worked very closely with people from the public health school who were either MPH students or people with various degrees in public health who were valuable as allies. And I think the biggest and most important thing that you offer from a public health perspective is a different lens, right? The way that you approach problems in clinical medicine is very algorithmic. There is a system somewhere that everyone looks to answer a question. Everyone goes to UpToDate, which is like Google for people in healthcare. And there is a very specific protocol that you follow, and that's how you take care of patients. And I think some of the different forms of problem solving, some of the different forms of looking at a problem that public health engages in, really taking things from a systems approach, is immensely valuable and a very important way to approach changing a healthcare system. And so I think that's the biggest value add that I've seen from my public health colleagues and something that I'm very elementary in currently, but hope to keep developing as well.
I think to build on what Neil Singh said, I think public health is so important. Medicine takes such an individualized approach to care, and I think it's so important to be looking at these issues, both at the individual level and at the systems level. And so, bringing in kind of as many disciplines as we can, and seeing how we can collaborate to, change the built environment and policy and and the structure of health systems, all is going to be so important to supporting our patients.
Yeah, I would just echo that incorporating as many disciplines as possible, social workers, people who are making the policies, historians of medicine who have an understanding of how this has changed over time, really is how we collectively get to a better place for this group of patients. Another question that we have is, many of you have talked about getting buy-in from different groups in your respective efforts. The question is, do you have strategies to navigate getting this buy-in or recruiting advocates in this space? And I would tack on, have there been times where you had to work extra hard to get buy-in, and how did that go, and what did you do to get there? Dr. Sa, I'm wondering if you could start us again.
Yeah. So, I think the first part is going to be like, who are your stakeholders, right? I think a lot of the answers are obvious, like you're going to have your hospital admin, whether it's your medical director, you have your nursing leadership. And then I actually found like our hospital risk team was quite helpful. A few things. One, I think there's a difference between kind of like the acute problem, right? Like the guard won't let me contact the parent of a minor who needs to go to the OR right now, right? And so kind of like flagging it for risk management and kind of speeding things along. I think when you have, right, you're playing more of the long game and you have time, I think the first thing really is like figuring out who these people are and also figuring like what do they care about, right? Like, are we more image conscious? Are we interested in, decreasing length of stays in the hospital, right? And maybe there's things like I can't do a paracentesis because this patient's shackled, so they're going to have to get admitted for empiric antibiotics for 48 hours until the culture comes back, versus like we could have just, unshackled the patient, done the paracentesis there. So I think those things have been helpful. I am a little bit, I'm trying to work through myself though, like how much I think that actually helps in the long run. Derek Bell was like a legal scholar who talked a lot about like interest convergence. His whole argument is like systemic change only happens when like the interests of your minority group align with the powers that be, right? But like there comes a time when like push comes to shove and we actually have different motivations. And so I think like, yes, it's important to figure out like what is everyone's agenda, but I'm a bit of an optimist and an educator at heart, is like, can we actually like try and start making pitches for like why this is like, the ethical, moral thing to do while we like have those relationships along the way.
Thank you for that those practical insights. Others on the panel?
I can add that this is less from a hospital policy perspective and more from like grassroots movement or like organizing efforts. But I think that kind of knowing that you should anticipate some obstacles and anticipate that interest is going to change over time and that people will move from different organizations and different positions. Because I think that something that this course and the student organization faced was that during COVID, a lot of the initiatives kind of just stopped and people ended up moving out of the partner organizations that we initially collaborated with. And so that wasn't necessarily opposition, but it was that something that existed in the past was a lot harder to re-implement. And so I think casting like a wide net for organizations that you want to work with, even if it's not necessarily in the like medical field, I think knowing that you can form alliances like outside of that, and then contacting people outside of your academic institution. Like I think this panel was like an amazing chance for us to hear from other people doing this kind of work. And I think that we would all love to see our work like expand beyond our own institutions. And so like don't be afraid to reach out to people, because I think once you put yourself out there, you can figure out like who's willing to like work with you, and they can help you figure out what obstacles there are and how to overcome them better too.
Karen, I loved your first point because it reminds me of something an organizer in Connecticut, Lorenzo Jones at Catal, has said to me in the past, which is the way you get movement is not actually through the group that is harmed. Like the way you get movements around veterans' rights is not always actually through the vets, but it's through people who love those people, because there's many, many more people who love that person than just the affected person themselves, right? And so the way you get things done maybe too for changing care for incarcerated people is through people who love those incarcerated people. So that's community organizations of families of incarcerated people, activist groups, right? Who can sometimes align with your interests and work with you to make broader policy change. I've been trying to think about that increasingly more. Like I just loved that, the multiplier effect. I didn't want to interrupt. Neil Singh, did you want to add in anything there? And so that, yeah, go ahead, Tyler.
I loved your second point, Karen, which was to not be afraid to reach out. And I hope folks on the call do not feel any fear of reaching out. I'm seeing so many names that I recognize of med students across the country. Many I consider friends who have joined and are doing such amazing work. So just really encourage folks to reach out to folks on this call and others, as Karen did as well. Back to you, Dr. Puglisi.
Sorry, but I think that also gets me thinking to a question that we had thought of even ahead of time, which is like, what is the role of incarcerated people and previously incarcerated people? And some people who have joined have kind of shouted that out a bit in the chat here in creating curricular change for med students. I have my own ideas on this, but I wonder what y'all think.
Yeah, I think one, like, I was actually reflecting when you had asked, like, are there things I would have done differently? I think that I would have incorporated, like, basically I was started from the source, right? My didactics and curriculums that we designed was very much from like my own experience as a learner, feeling like we were not doing something right versus actually hearing from incarcerated patients like, hey, what is bothering you? What makes you feel more stigmatized? What are things you want us to change? We were really lucky. There was someone who had lived experiences with the carceral system and worked for the ACLU, and she actually would come and give talks to us a lot of times. And I think because of the inequity in our like medical school training process, a lot of people actually don't have direct contact with the carceral system or have met people with those lived experiences. And I think that was a really powerful moment for our learners to actually, hear about her own experiences and how that came about. So that's one thought I have. I know there's also like the inside out prison exchange where you're able to actually like come in and have dialogues with the prison. And it's also, so beneficial for us as like medical professionals to get that kind of knowledge too. And so that's something that I'm interested in looking more into.
I agree with everything Dr. Seo just said. And one of the things that a mentor of ours, Deb Goldfarb, who's a social worker and also the director for behavioral health at the Graken Center here in Boston, she's organizing an amazing group of people to hold like listening circles. And they've had a couple already where she's invited people who are formerly incarcerated and then also people from healthcare administration and clinicians and also people from the justice system to all literally sit in the same circle, about 15 to 20 of us, and just share stories. And everyone, one of the questions we were asked in one of the sessions was, what's something that's important to you that you wish everyone else in the room knew? And the answers to that, like I still have some of those quotes that I carry with me. And I wish that was, again, more common practice where medical students and clinicians in general could hear from these people and from all people, right? Like all stakeholders that are involved in these issues have the space to share what's important to them in a very like safe and protected space.
Karen and Victoria, I wanted to follow up specifically with that question for you all, because if I recall, it seems like you all started the selective with conversations with individuals who had been formerly incarcerated. Is that correct?
Yeah, so I think, and Karen, jump in if I'm getting this wrong, but my understanding is that the selective was kind of born out of a student organization that hosted panels of incarcerated people. And then somewhere along the way, that organization kind of died out, but the course lived on. But one of the things that we learned, actually, as we were preparing for this webinar, we were able to get in contact with the medical student who had started the course. And she shared her, publication of what they had done. And we learned that a part of the original course that had also gone away over time was that they originally had letters from incarcerated people describing their experiences trying to get healthcare. And so that's something that I think we'd really like to bring back. And I think it's been such a valuable perspective to have a faculty member who has personal experience with incarceration lead one of the sessions. But I think maybe one of the ways that we can push ourselves is in, trying to get more input from people with lived experience in like what the curriculum actually looks at, what they think it'd be important for us to know. And then also as we like look towards starting a student organization again, having that really be guided in terms of the advocacy work or issues that we address, having that really be guided by people currently experiencing incarceration.
Thank you for sharing that additional follow-up. We're approaching near 2:30, but I want to finish with One last question that may be another difficult one, but I want to pose it to all of you. You can have some time to think. It was asked from an audience member, and the question is, how do you grapple with the complexity of serving within carceral systems while concurrently hoping to dismantle them, i.e., decarceral abolitionist perspectives? So I'm wondering if you all could give a response to that in light of the work that you're currently doing.
I'll jump in. I mean, yeah, I think that is like the inherent tension, but I am a bit of a pragmatic idealist. A few things. One, I think, you know, part of what makes incarceration feel so dangerous to me is just how dehumanizing it is. And I think like trying to respect the humanity of everyone we come into contact has been important. I think on a bigger picture level, I'm going to actually do a plug for a different organization, Medical Justice Alliance. I think Nishi Kumar is on the call, but basically they're a nonprofit that partners physicians or trainees to provide expert testimony to try and actually apply for like medical compassionate release. And that's been something that I found really meaningful, right? I think there's a new book that just came out called Dismantling Mass Incarceration by Premal Darian et al. I highly recommend it because it gave me a lot of food for thought. But I think of like, one, we have to actually try and not like do good with the power we have, but actually how can we like try and, you know, disband that power and not be such like, paternalistic authoritative figures over our patients' lives. And then I think second part of that is like, how can we actually try and like limit incarceration itself as well as like, the impacts that it might have. And so I think in regards to the participant, and thank you for that question, I think I try at least to ground all of my work in like, but we should not be having to do this. And like, is there actually a way that we can work towards the bigger picture of abolition?
Thank you, Dr. Suh. And I particularly loved that comment on dismantling or disbanding our own power that we recognize we hold. Would others on the call like to chime in on this question?
Karen, go for it, please. Okay, I'll just chime in real quick. I think one of my mentors said something to me once. The concept of like uncomfortable complicity, where you are trying to change a system, but you are also part of that system, because that system is causing harm. And I agree with the concept that it exists. And I think to Dr. So's point, it's how do you translate the power and privilege that you have and give it to the right people? But also, how do you kind of create a space where these problems aren't going to exist for future patients? And I think every time there's an issue, for me personally, every time there's an issue, being able to trace that back to, okay, but why does this problem exist? And if you can answer that question from a systems approach, then you kind of know where you can target your efforts. And that's really helpful. But there's a very good question. Thank you to the audience member that asked this. I think I personally have just tried to figure out what specific things I can motivate and where I can make noise. I think a lot of times where it takes a lot of, again, privilege to be able to make noise in these spaces because you know that you can say something when something is wrong. But every time we have the chance to make it clear that, hey, this is an unjust process that's happening that we're witnessing, and I just want to say that I disagree with this. That is a good thing and that is a powerful thing. And so I encourage all of my colleagues, to the extent that they're comfortable, to say things when something is wrong or something is unjust, because I feel like that's how you create a small but existing and growing momentum towards preventing it from happening in the first place.
Thank you for those call to actions. Karen, would you like to go next?
Or this question is really interesting to me because like when when I was doing my history research, it looked not necessarily into abolition of prisons, but it looked into deinstitutionalization of asylums. And so that process is actually kind of parallel, I think, in many ways. And just really briefly, because I feel like I can go on about this for a long time, but I think it's really important to think about what like social purpose these institutions are serving, because like Dr. Suh said, it seems like the carceral system is absorbing the people who were not addressed by the medical system, by the rest of society. And so that is kind of in a lot of ways similar to what asylums were like. And when deinstitutionalization took place, unfortunately, there were not necessarily the community programs and community mental health, like housing support, job support in place to kind of help people who were deinstitutionalized reintegrate back into society. And then in response, there was kind of this backlash to deinstitutionalization that people ended up pointing more towards deinstitutionalization as a reason for the increase in incarceration. And so that relationship has always been really interesting to me. I think that's something that's really important to consider, that when we think about abolition, what are the steps that we need to take to ensure that once a system is gone, what's going to take its place, and how can we create like a more humane society for the people who come out of that system.
Thank you so much to our audience for having joined us today, taking an hour of precious time out of your day, an hour and a half, to be a part of this conversation and this learning environment with us. I'm grateful. I'm also grateful to our panelists. Thank you for making time for this. Thank you for the work that you're doing. Thank you for being so thought-provoking today. I'm going to close up by summarizing some of the things I'm hearing. But for learners, we heard a lot of physician talk today, but there were a broad array of learners on the call. So for community health workers, for nursing students, PA students, for health professions learners across the country, I'm hearing some components that they can go back to their institution and think about. One is kind of understanding the needs of your learners. So what exists already in your institution and where are their holes? What are the community's interests? So what do people with lived experience in your local community want and need in healthcare system change? Hearing opportunities for student reflections after intervention. So really like thought-provoking reflective time. I'm hearing about bringing in practitioners who have experience of practicing behind bars and maybe also in the community. So giving this sort of broad range of practitioner experience to expose students to. I'm hearing about simulated learning and thinking about opportunities there, as well as specific clinical rotations, even behind bars, core curriculum changes so that everybody gets exposed to something, and then maybe people with deeper learning interest get to dive deeper. I'm here. So I'll stop there. Those are some of the big reflections I have about stuff you've done. Also then kind of thinking how you translate curricular learning into policy and practice work and vice versa. So that now that BMC has done all this really cool, awesome policy work, how do you translate it backwards or I don't know, in some direction into curricular learning? So how do the students that come after you learn that this was done, learn how to think about it, how to use it, how to interact with these policies? I've had a lot of food for thought on this call today. I know Tyler and I at Yale, along with other colleagues, are doing some fun work that I hope you all will stay tuned for regarding community engaged curricular development. So having community members part of the curricular development, experiential learning practices, and also thinking through hospital pathways that can help normalize learning around caring for criminalized populations. So stay tuned, more to come there. And Tyler, I'll let you do our final wrap up.
Yeah, thank you. And thank you all to our panelists for taking time to share your experiences, what you have done in your respective spaces. I just appreciate that so much. I think, Dr. Puglisi started us off by talking about a long history and tradition of folks doing this work to improve care for marginalized patients as a whole. And it occurred to me throughout this that what you all are doing in your respective spaces will also become part of that history in future generations. So just so much respect and glad we could gather in this space with one another together and think about what health system we want to inherit and what role we play in creating that for ourselves and also our patients. I would like to thank everyone who took time out of their day to join. As a reminder, this will be recorded and shared with folks. We've several of us have posted our emails in the chat for folks to reach out to. I would say especially other students and learners across the nation to really spark conversations about how we can keep this work going and start new work. And then lastly, a thanks to our co-sponsor, the Health Equity Thread here at the Yale School of Medicine. We hope you all have a great day and keep in touch with us as you keep doing this amazing work. Thank you all.
Thank you. Appreciate you all. Have a nice day.